now listen in to the president of SPIN, Ozgur Oztekin. As we started earlier on, we said this was going to be a promo event for our SPIN Fellowship academic year, which concludes in Dubai later on. We hope to see some of you there. But we are concluding the session with a very good friend, a good mentor, as well as a big support for all the causes that are good to the world, Ozgur Oztekin. Please reveal yourself. Yes, I can see you. And please take it from here as we have the showstopper of today's sessions.
Hello, everyone. First of all, I would like to thank you, Kish. Very special thank you. All the effort you put into making this meeting accessible for all of us from our homes and workplaces in the comfort of our environment. A big thank you to Harshita Menkat, who has always been there for us, especially in the very toughest times. And lastly, our admin guy, Mohammed, thank you very much. Young guy, very strong guy. Thank you very much. And our speakers, thank you very much. Being the last speaker is sometimes a challenge, but also a blessing because I had the chance to skip a few of my slides thanks to the excellent presentation before me. Camilo made the technical part very easier, and Kish covered the orbits, which is a part of the head and neck itself. My work is a little bit easier now. So now let's jump into my session. Fetal MRI is a valuable tool for evaluating normal facial anatomy for delineating the extent of head and neck masses. Abnormalities of the fetal head and neck represent a broad spectrum of conditions, including both malformations and masses. Single-shot T2-weighted sequences are the workhorse of fetal MRI. Camilo very well summarized the technique today in very early session. In my daily practice, haste and trophy sequences are the most helpful two important sequences. And also, sometimes the susceptibility weighted and T1 weighted sequences are problem solving itself in some of the difficult cases. MRI is also known to show facial and cervical anatomy of the fetus in high anatomical detail, a true midline sagittal image. And parasagittal MR images are very important in assessing the facial profile. Forehead and chin must be on the same plane. The nasal bone should be present, and the nose and its curvature is very important. The top of the ear should always be above in the same line with the orbit. The upper and lower lips, the primary palate, and the secondary palate should be visible. The primary palate includes the anterior portion of the alveolar ridge with the 4 incisor teeth. The secondary palate consists of the remaining hard palate and the soft palate. And cine image is very important in evaluating the swallowing function and visualizing the normal anatomy. Here you can see the upper and lower lips very well. Tongue, chin, nose, primary and secondary palate very well. The oropharynx and the nasopharynx are also assessed on the sagittal anatomic plane very well. And also oropharynx, nasopharynx, trachea is very well appreciated in the sagittal images. The alveolar arcus with the tooth buds and the hard palate are very well identified in axial plane at the maxillary level. The nasal cavity is depicted as small slit-like hyperintense areas containing amniotic fluid on both sides of the nasal septum, and the spacing of the eyes, optic nerve, vitreous, lens is very well appreciated in this plane. And the coronal image is also very important, especially in the measurement and evaluation of the integrity of the fetal lips and the palate. And abnormalities of the fetal head and neck are an extensive group of diseases that include malformation and masses. We will focus on cystic masses of the head and neck mainly in this remaining part of my lecture. Try to analyze these graphics, the approach. In the prenatal period, there are many different types of scalp masses. The hemangioma, lymphatic malformations, dermoids and epidermoids are some of these lesions. And meningocele and encephalocele are also considered in the scalp lesions within the calvarium. And there's a calvarial defects in these two lesions in meningoencephalocele and encephalocele. Algorithmic approach is very useful. This is based on initial identification of the presence or absence of the vascularity in the scalp lesion. The next step is to look for underlying calvarial defect. If there's any calvarial defect or if there is no defect, we should look at that one as well. Let's start with this simple case. Actually, it looks simple, but it's life-saving. Extracranial fetal masses are findings of major diagnostic alarm of which encephalocele is the primary consideration. Doppler ultrasound revealed no solid tissue components or vascularity within this lesion. Power Doppler showed no abnormal communicating vessel beneath this lesion. According to our diagnostic flowchart, the algorithm points toward the cystic scalp lesion of the ectodermal origin, such as dermoid or epidermoid cyst. On MRI, the lesion shows no evidence of intracranial communication, and misinterpreting this lesion as an encephalocele could lead to unnecessary termination of the pregnancy. We have to be very careful. Therefore, when we detect a lesion in the fetal scalp near the anterior fontanelle without intracranial communication, a dermoid cyst should be considered as a major differential diagnosis. The presence of intracranial communication in an avascular scalp lesion, this is actually this girl is after birth, 7 years after, visit my office, and she has this lesion, and this is very important. Being a doctor is very important. We should never forget that. The decision we make deeply impact the lives and are incredibly important in the lives of other people. The presence of an intracranial communication in an avascular scalp lesion suggests neuroectodermal conditions such as meningocele or encephalocele. When a midline cystic scalp lesion is detected, evaluating the venous anatomy is crucial for diagnosing atrophic cephalocele. We should look very careful. These are very classical lesion, and if we know this location of the lesion and the associated findings, we will find the diagnosis very easily. Let's move to the second question. One of the twins was found to have a scalp mass, and the case was referred to me for further assessment. The mass demonstrated a broad-based scalp attachment with no associated skull defects or abnormal findings. MRI findings of mixed signal intensity with internal signal voids together with prominent Doppler flow supported the prenatal diagnosis of fetal scalp hemangioma in this time. Early suspicion and diagnosis of hemangioma is crucial as it can influence both mode of the delivery and timing of the delivery. These images are obtained 3 months after birth. If you compare with the prenatal images, there is a significant reduction in the size of this lesion. Congenital hemangiomas grow in utero, unlike infantile hemangiomas, which typically develop postnatally. And given the spontaneous recognition, without the treatment, this lesion was classified as rapidly involuting congenital hemangioma. And now let's go through another case. On coronal images, there is a significant accumulation of the lymphatic fluid within the subcutaneous tissue. Due to its large size, the lesion exerts a mass effect on the neck, resulting in postural abnormality. However, it doesn't cause significant compression of the trachea, and if you carefully look, there is no compression of the trachea and areoepiglotic fold, and there is no compression on these anatomic structures. Lymphatic malformations are typically located in the posterior subcutaneous tissue actually, but they often extend laterally and may be confined to one side of the neck, leading to the postural asymmetry. Here is another patient presenting with findings similar to the previous one, a large cervical mass causing significant hyperextension of the neck. Internal small septation is visible, very characteristic. And another patient. In this patient, you can see multiple solid, you can see multilobulated, huge mass, both has the solid and cystic compartment, including both the intracranial part and the oral part. Although congenital oral masses are rare and can readily be detected during fetal ultrasound screening, fetal MRI follow-up always gives us more specific diagnosis by applying a strong, straightforward anatomic approach. The anatomic side of the origin plays a key role in determining the correct diagnosis of congenital oral masses. This giant oral mass is distending the oral cavity and growing bidirectionally. Some part of the lesion is protruding into the amniotic cavity, and remaining parts, major part actually, growing and infiltrating the skull base and looking like an intracranial mass. This is another case. In this time, a left paramidline anterior neck mass is identified on the coronal MRI. And there is also cystic and solid structure on this lesion as well. We have already reviewed these first two cases, including lymphatic malformation and congenital hemangiomas in the similar areas. Both of these should be considered in the differential diagnosis of the head and neck masses when we look at this kind of solid and cystic mass. Cervical teratoma typically present as anterior neck masses causing hyperextension of the neck, and they are usually bulky, multiloculated lesions with heterogeneous signal intensity depending on their internal composition. And this will be the last case. I will conclude my presentation with this final question. This is an exceptionally large mass, nearly equal in size to the fetal head. It's located on the lateral aspect of the neck. However, due to its considerable size, it's challenging precisely determine whether it is situated anteriorly or laterally or posterolaterally. This is challenging. This was a particularly difficult case, really difficult case, even not only for the radiologist, for also pathologist also this case was challenging. Based on the initial pathological examination, this lesion was described as small round cell tumor. Following further analysis, pathologists finally diagnosed this case as grade 4 embryonal tumor. This patient is the 3 years old sister of the same patient. This girl also has the diagnosis of embryonal tumor. This was the pathological specimen, and after birth, this lesion is similarly appearing. And familiarity with this spectrum of common and uncommon head and neck malformations and their appearance on fetal MRI is essential not only for confirming and complementing ultrasound findings, but also for family counseling, prognostication, and planning postnatal management. It's very important. Fetal neck masses are uncommon, but critically important as they may lead to life-threatening airways obstruction during the birth. An MRI is valuable tool for lesion characterization, for assessing the relationship of these masses to the airway and the head and neck vessels, very complicated anatomical region. And counseling the cases, the clinician is very important in these cases as well. As I conclude my presentation, I would like to take a moment to remind you of the upcoming SPIN 2025 meeting, which will be held this November in Dubai. Hopefully, we will meet with some of our speakers and our friends in Gulf, in Dubai. Hope to see you, most of you, in Dubai 25, SPIN 2025. And thank you very much for your attention, starting from the morning to the night in Izmir, and maybe in some countries, in some parts, from the midnight till the morning. Thank you very much.